Okay, Chapter 4, Medical, Legal, and Ethical Issues. This chapter has a lot of information in it that will be very beneficial for the remainder of the course. One of the things I think that often gets forgotten about when we talk about treating people and coming into contact with patients and assessing them, so on and so forth, have to do a lot with the medical, legal, and ethical issues that we come across. Everybody thinks, oh, it's all about hands-on treating the patients and so on and so forth. But in reality, a lot of it has to start with the medical, legal, ethical things before we even get to those other parts. So their objectives obviously are listed in your text on pages 74 and 75. And there's a multimedia video course for you. But our core concepts that we really want to concentrate on is the scope of practice of an EMT, how a patient may consent to or refuse emergency care, the legal concepts of negligence, torts, and abandonment, what it means to have a duty to act, and the responsibilities of an EMT at a crime scene. So we start with scope of practice. So what is a scope of practice? Well, scope of practice is regulations and the ethical considerations that define the extent or limits of a job's duties. Typically, we consider this to be skills and procedures. Sometimes we also will define it with some of the assessment techniques that maybe really aren't a skill or a procedure. Now, scope of practice in a strictly regulatory sense is usually determined by state law. The national scope of practice model is really what they designed the new EMS provider levels off of, and that really kind of rolled down to the states. The national EMS scope of practice model was the same foundation for all the states across the board. Formerly, there was somewhere around 47 different levels of EMS provider throughout the United States, and this was a problem. Even across the river, across the Missouri River, the Iowa-Nebraska border, there were significant differences between the two states and what their respective provider levels could do. The two states basically had the same providers. They may have had some slightly different names, but then when we really got down to the brass tacks, there were some fairly significant differences, and this could be an issue for those people that work in a border town or in a border community, whether it be Nebraska-Iowa border, Minnesota, South Dakota, Illinois, Missouri. Any of the states really have that potential to have major issues if there would have to be an instance in which there was a large-scale incident that required mutual aid from across the border. Now, typically when we talk scope of practice, we're actually talking more about state, and the state says, here is the maximum of what you can do. And that state scope of practice is really what guides local practice. And that state says, okay, you can do this, this, and this, but the next level can do this, this, and this, and the next level can do this, this, and this, and then there are certain things that they say nobody can do. So, for example, a paramedic is not allowed to do a field C-section. It's just not allowed. Local laws can further refine this and can further pare this down and say, well, this may be allowed in the state, but our medical community does not feel that it is appropriate, so therefore we do not want you doing this. And then, of course, protocol. Protocol is what is referred to as offline medical control, but protocol is really a driving force, saying, in our town, in our county, in our system, this is what we do for patients with chest pain. This is what we do for patients with altered mental status. And the standard of care. This is a care that's expected from an EMT with similar training for a patient in a similar situation. I like to refer to this as the reasonable person theory. So what would a reasonable person that has got the same basic skill set as yourself, what would they do in the situation? So it would be really one of those things where they'd say, out of 100 EMTs surveyed, would they have done what you did? Or would the simple majority or the large majority of them say, no, I would not do that? So meeting the standard of care reduces the risk for legal action. If this is what the standard is, what people are doing, then this is what is probably going to be the accepted by a jury of your peers. This kind of comes around from time to time, and one big thing that's really kind of a standard of care issue right now is spinal immobilization using a long spine board. This has been a mainstay of EMS treatment for years, decades, was to use this backboard. Well, they're now starting to find scientific evidence that says, you know what, we're really not doing a lot of people very much good, and in fact, in some cases, we're really causing more harm than good. So there's some discussion about maybe we don't need to immobilize every person we come into contact with. Maybe we need to do a little bit more assessment in the field to determine, do they really need this backboard or do they not? Scope of practice is what you can do. The standard of care is how you should do it. So the scope may say do this skill, do that skill. The standard of care says do it this way, do it that way. So ethics. These are your standards that govern your actions. They're not always required by law. It's kind of the golden rule standard. That's kind of an ethical thing, saying do unto others how you would want done to yourself. So I mean that's probably the biggest moral that somebody could have. It's very important to EMS, is treating people the way we would want to be treated, treating them to the best of our abilities, and doing so in a manner that is generally accepted. Ethics don't play as much of a part in EMS as it does in, say, some health careers. Say, for example, you may have hospitals that are run by churches or doctors of particular faiths, or even a pharmacist of a certain faith that say, we're not going to do anything that has to do with contraception. We won't do any sterilizations. We won't give out birth control pills, whatever. And that's something that ethically gets shaded a little bit by a person's background. Luckily, that's not a choice that we have to make very often in EMS. However, there may be some times that ethically you may not agree with the way that we're supposed to do a certain procedure, and you may have to decide which way you're going to handle this. There are some times in which people are instructed, stay home. If this call sounds like it's going to be this, stay home, because it could potentially put you in an ethical dilemma. So good ethical behavior is what you do when no one is looking. I mean, I think we've all heard that sort of statement before. The true measure of a man is what he does when no one else is looking, or he knows he's never going to get caught. So that kind of a rough idea of what's considered good ethical behavior. So you can view this video by going to the regular PowerPoint. Patient consent. Permission from the patient to assess, treat, and transport. This has a couple of angles on it. First of all, whenever possible, we want to acquire expressed consent. And that expressed consent should also be an informed consent. So what's the difference? Expressed is when they say, yes, I would like your help, I would like your care. Yes, please assess and treat me. That's when they are expressing to us their wishes. In order for this to also be informed, we also need to let them know, whenever possible, the risks and the benefits of our actions. Sometimes people might say, do I really need to have this backboard? Do I really need to have this splint on? Do I need, in a paramedic situation, do I need an IV or do I need this medication? And in those cases, when informed consent really comes around even more, is if they bring it up and they're like, I don't really want that, then you need to make them aware of why you think it's necessary, what the potential benefits are, and what the potential downfalls are, what are the potential complications that may come about. So by giving them the full picture of the good and the bad, we can then give them the information they need to make that expressed, informed consent. Implied consent, on the other hand, this is kind of an assumed consent. And implied consent often has to come when a patient can't express consent to us, regardless if it's informed or not. Again, this is another time in which you kind of have to use that aforementioned rule, the reasonable person theory. We stop and think about this for a minute. We're like, would a reasonable person want to be assessed, treated, and transported? And in most cases, I think we can say yes. So there are certain times in which we have to take some implied consent. There are other times in which we have to do some involuntary transportation. We have to look at people who are incapable of giving informed, expressed consent. And in those cases, the consent for children. So this is a special type of implied consent. The implied consent, in the classic sense, we usually would talk about, say, an unconscious adult. That unconscious adult can't tell us, yes, I would like to be treated and transported, so reasonably speaking, most people would want that. In consent for children, minors are not permitted to provide consent for treatment. This is under the age of 18 in Iowa, 19 in Nebraska. The minor cannot provide consent for treatment with a few exceptions, and we're going to attempt to obtain consent from a parent, legal guardian, or in loco parentis, somebody who is standing in the place of the parent when the parent cannot be located. Now, if the patient has a life-threatening injury or illness, we are going to kind of fall back on implied consent and say, we're going to treat and transport this child. If in the case that, let's say, this one comes up fairly frequently, you get called to a vehicle crash and show up, and it's a bunch of teenagers out dinking around, being teenagers, and they've had a little fender bender, maybe some complaints of, oh yeah, my neck hurts a little bit, but I don't want to go to the hospital. That's not good enough. We're going to have to talk to the parents. So you have somebody dying, you treat and transport the person that's dying, and have another truck or somebody else stick around and try to contact parents. If you can't get a hold of a guardian or a parent, then you are probably going to have to go ahead and transport that child up to the hospital. A few other oddball situations that pop up. Emancipation. Emancipation is the court saying legally this is an adult. They do not have to get parental consent for the standard parental consent things, marriage, medical care, so on and so forth. There is also minors who have children. They kind of have moved into a different class because now they are parents themselves. A parent wouldn't, in theory, I guess if you look at it this way, if we didn't give minors the ability to consent, minors who have children the ability to consent, we would then have to ask grandma and grandpa if it's okay to treat the grandchild. So that's why minors with children have kind of stepped up a step on the totem pole. Minors who are married generally fall under the same situation as do minors serving in the armed forces. Minors serving in the armed forces, generally they're old enough to serve their country. They should be afforded some of those rights and privileges of being an adult. Consent for mentally incompetent adults Now, when we say mentally incompetent adults, this is not strictly people who are maybe developmentally disabled. Sometimes we all get a little temporarily incompetent, and in those cases we may have to involve several other agencies to help us with this decision. The primary population we're discussing here really is those that are developmentally disabled, but in reality this also extends to those that are not within their right mind for a time period, whether this is a chemical issue, they're under the influence of something, maybe they have a behavioral emergency that is making them not make appropriate and wise decisions. So state and local laws will permit us, and as well as protocols, to transport patients under the implied consent rule. Now, if we can try to get somebody that will back us up in this, that's going to make our life a lot easier. So if we have a family member who is urging us to transport and is trying to consent for this person, that makes our job a little easier. If we have to do an involuntary transport, where we have somebody who either A, is not within their right mind, not within their faculties to make appropriate decisions, and is absolutely refusing. Sometimes it's a person that is considered a threat to themselves or others. Sometimes we have a court order, and oftentimes it's going to require assistance from the legal system, and probably should also involve medical control as well. So if this is the case, we're going to get as many people on the same sheet of music and say, okay, here's where we're at. How are we going to carry this out? Does this meet everybody's definitions that they need it to meet? And what else do we need to do to make sure we're covered here? If the patient is restrained, it must not be a legal liability. You really have to be careful when we're restraining people. The patient can quickly go downhill. There's a number of patients each year that, while restrained or while in police custody, suffer an interesting medical emergency that occurs from time to time, and we have to be prepared for the patient to have very negative medical consequences occurring rather rapidly. So, refusal of care. So a patient may refuse care or transport if they are, number one, legally able to consent. So they either have been granted this ability via the courts, they have perhaps are already of the age of majority, and they're within their faculties, so they're mentally competent and oriented. They know what's going on. You fully inform them of the risks and the benefits. You shouldn't leave the benefits out. Sometimes the benefits are the selling point. You can go ahead and tell them, hey, if we leave you here, your medical condition has been known to cause this, that, and the other thing, up to and including death. And then, if that's the case, then sign. If they still choose to not go with you, have them sign the release form. Get as many people to back you up as possible. Family members, have them sign that they were witnesses that you tried to get them to go. Law enforcement, if you can get several people signing as witness, backing you up, the better. Despite all precautions, you can still be held liable. Now, from time to time, we run into these situations. Sometimes it's people just trying to be proud, trying to get, trying to be tough, and it's really one of those things that if we do a good job of informing them, we often can get them to go along with what we're trying to do. So we'll take, for example, I responded to a chest pain once in a doctor's office. Picked the patient up to put him out in the ambulance. I could tell that the guy was having pain. He was wincing and kind of clutching his chest. But whenever I'd ask him what his pain was like, oh, I don't have any. And I finally had to stop and look at the guy and say, look, you don't have to be a tough guy. I says, because you know what we do on Tough Guys? And he kind of looks at me and says, no, what? I said, CPR. I said, look, if you're having pain, we should treat it now before we have to go down that road. And he finally said, okay, I am having pain. Now, while it was probably not the most professional approach to it, it got the idea across that, hey, this is a serious situation. I can tell you're having pain. I can tell that this is an issue. Let's just deal with this. Sometimes also you can make deals with the patients. And you do this in front of family members and so on and so forth, that, hey, if we get called back here, will you agree? If I let you sign off now, if I get called back here in the next 48 hours, will you agree that you will go to the hospital? No ifs, ands, or buts. And a lot of times they will agree to that. And you do that in front of the family members, and the next time the patient has a little twinge of pain, they call 911. You're right back there. You pick them up, and they're like, well, yep, I agreed. You're back. Let's go. It doesn't always work, but sometimes it helps. So, if in doubt about a refusal, discuss this decision with the patient and the family members and the friends and the bystanders that are appropriate to discuss this with. You know, if they know this person and they're concerned for them, it doesn't hurt to, as long as the patient's okay with it, have this discussion in front of them. So ensure that that patient understands the risk. Contact medical control. Let medical control maybe even talk to the patient. Contact law enforcement if necessary. Have law enforcement come out and back you up. Law enforcement can place a patient into emergency protective custody, and in most cases, as long as the patient is within their right mind, they're not going to do that, but it's still a good idea to have them available. And then listen to the patient to try to determine why they're refusing care. Maybe they don't fully understand the situation. You know, maybe they have a general concern about a fear of hospitals. They have a concern of the financial impact. And maybe it's something that you can discuss with them. Look, you know, if you're just having a little bit of chest pain now, we can set this up. You know, maybe it's something that's not terribly bad that we can get you found. We can get it found, get you started down the right road to treatment, as opposed to we wait till it becomes a very big deal. It's most likely going to become much more expensive. So think about it, things. What are the risks of beginning treatment or transport without getting consent from the patient? And what if the patient refuses to sign the refusal form? Well, beginning treatment and transport without getting consent technically is battery and could be considered false imprisonment. If you load them up, put them in the back of your truck and go down the road and they didn't consent to all this, there are those risks of some legal ramifications against you. What if the patient refuses to sign the refusal of care form? That is a super documentation nightmare. That's when we get statements from lots of people, we get signatures from lots of people, you tried, and that run report becomes very long. We have to document every single thing we possibly can think of. Remember, our run reports are really our only way of going back and saying, okay, here's what really happened on that call. So if we get sued 4 years down the road, what do we have to back us up? If you don't have a very well-written run report, you've got nothing. So additional things to consider during refusal. Have a witness. Inform the patient if they change their mind, they can call you back. If possible, have a friend or relative remain with the patient. If they won't allow you to transport them, will they allow a friend or family member to take them to the hospital? It would be better for them to just at least get to the hospital and be treated than to not get to the hospital and have the worst occur. So sometimes it's, tell you what, why don't we help you out to the car? We'll follow you to the hospital. If anything happens, we will intervene. But otherwise, you've got to ride to the hospital. You're going to get treated and seen. We would much rather that be the case than them stay home and have the worst case scenario. And again, document. So, advanced directives. What are advanced directives? There's a large number of different documents that can be classified as advanced directives. The thing that we're really able to do something with is a do not resuscitate order, a DNR. Now there's little consistency. It's becoming better. Each state is doing a little better job of looking at, let's try to standardize these things, but there's still a huge variation across the gambit, across the country, even in the states, the counties, the cities, large variations of what we actually see for DNR orders. DNR orders are signed by physicians. We take orders from physicians. Living wills, on the other hand, these are signed by the patient and usually an attorney, and this is a statement regarding the use of long-term life support and comfort measures, IVs, pain medications, so on and so forth. Normally, we have a very difficult time using only a living will as a means to withhold resuscitation. This would normally be something that we would want the patient to take to their physician and have the physician drafted the do not resuscitate order. If we're presented with a living will, our best bet is to get on the horn with our medical control, our online medical control, and say, here's the situation. I have this living will. Do you want me to honor it, or do you want me to start? Healthcare proxies, also called powers of attorney. This is a person whom the signer of the document names to make healthcare decisions in their stead. If they're unable to make those decisions, these are the ones that they want to make those. This does not prevent you from doing comfort measures. So giving them some oxygen, or at the advanced level, maybe it's giving pain medication or some IV fluids. But for the most part, this is not to do things that are invasive. No airways, no breathing for them, no pushing on the chest, no shocking them. That's generally what these are trying to avoid. So now, to be very explicit, most DNR orders really need to be on a physician's letterhead or a specially provided form signed by the doctor. Very, very detailed explanations of what they do and do not want to occur for this patient. It should be signed within the last calendar, or last rolling year, last 365 days, to be at its best. Local protocol may give you a little bit more leeway. If you're working in a small town where there is one doc or there's just a couple of docs, things may be a little looser. So additional legal issues. Negligence. Okay, negligence means that something that should have been done was not done or was done incorrectly. So if it was not done, it's an error of omission. If it was done incorrectly, it's an error of commission. You committed an act that was incorrect, or you omitted an act as the act of omission. You didn't do something. So those are the two major cases for negligence. In order for you to find negligence, there has to be a couple of things occur. Number one, there has to be a duty to act, and that duty to act is an obligation for you to provide care, saying that while you're on duty, you're obligated to provide care if no threat to your own safety. Duty to act is not always clear, though. What about if you're off duty? Okay, a lot of times if you are on a schedule, you are on, let's say you're on call Monday, Wednesday, and Friday from 7 a.m. to 7 p.m. and it's Thursday at 9 p.m. You're not on duty. Are you obliged to act? Well, this is really more probably a ethical question than it is a legal question. If you have a system that's set up that people are only on call certain times, you most likely do not have a duty to act. What if you're on duty out of your jurisdiction? You're in the next town over, you're in the next county, you're in the next state. What are you supposed to do? In most cases, you would provide basic life-saving measures, the CPRs, the bleeding controls, foreign body airway obstruction, that sort of thing. But in most cases, you're not running around with an AED and a bag full of all kinds of medical supplies, nor should you be. I mean, it's one thing to do a little bleeding control. It's another thing to whip out a traction splint and put it on somebody's broken femur if you're not supposed to be on that call. So obviously, local law, local protocol are going to dictate a little of this. You're going to need to look at what your local system, what your local system's expectations are, and of course follow your own conscience. I mean, if you're sitting right there and something happens, most of us are going to react. We're going to do the basics that we can to tide this person over until other help arrives, the on-duty help arrives. Now there are certainly instances in which we should not be acting. Let's say we've had a few adult beverages or something along those lines that have impaired our judgment. We do not have a duty to act. We should not act because we cannot make rational decisions then. So negligence, they have to prove that the EMT had a duty to act. So you were on the schedule or you were a volunteer. Now that if you don't have a schedule, then that makes it a little bit more gray. Things are a little more cloudy. When are you on duty? Well, you're a volunteer that carries a pager 24/7, and the first 5 people that show up at the station go on the call. You probably have a duty to act. If you're at home, you're in your home district, you probably have a duty to act. There has to be a breach of duty, and that breach of duty means that the EMT did something incorrectly, whether they didn't do something or they did something wrong. They have failed to meet the standard of care. There has to be an injury related to that. So the patient has to have suffered because the EMT did something wrong or didn't do something. And then there also has to be proximate causation, or I just like to refer to this as causation. Causation means that you have related that breach of duty to that injury. Now, do patients ever get worse under our care? Yes, it happens all the time. But in order for this to be a negligence case, we have to say the patient got worse because we did something wrong or didn't do something. And that was the reason why this patient worsened. So just because a patient gets worse doesn't mean it was a negligence case. It has to be related to something we did incorrectly or didn't do. So a negligent EMT may be required to pay damages. Your service is going to get it. Your medical director is going to get it. Anybody else who is involved is going to get it. And then the EMT that gets found is going to have to pay. There's a legal concept called res ipsa loquitur, meaning the thing speaks for itself. So this is a legal concept important in these negligence cases, in which they're basically saying, look, it's plain to see that the reason that this person can't walk anymore is because this EMT had him do 10 jumping jacks, even though he was complaining of back pain, and it has caused a shift in his broken vertebrae and severed his spinal cord. So, the reason the patient can't breathe on their own anymore is because they had a broken neck, they were immobilized on a backboard, but yet the EMTs didn't do a good job of keeping them secured, and the backboard slid off the cot, or the cot tipped over, or whatever. So those are sort of concepts that you might see there. A tort case, this is an action or an injury was caused by negligence that results in a lawsuit, and that lawsuit is a tort case. So it covers most proceedings or lawsuits against EMTs. This is referred to as tort law. And then the 2 most common and significant causes of lawsuits against EMTs are, number 1, patient refusals, that we didn't do everything we could to get them to go, and number 2, ambulance collisions. Everybody thinks that EMS is so cool because we've got those lights and sirens on that truck, and that they make us invincible, and that's absolutely incorrect. We are not invincible. There's a lot that happens, and those lights and sirens really are not that great. We'll find out eventually that 2 major facts have to loom over our decision to travel with lights and sirens. One, 70% of all fatality accidents involving an ambulance involve an ambulance running lights and sirens. And 2, the average amount of time saved if you run lights and sirens versus if you don't is 42 seconds. And in reality, 42 seconds is rarely, if ever, going to make any difference in this patient. Abandonment. Abandonment really is one of the major sins that an EMT can commit. So if we're talking abandonment, we may have started care for a patient and we either discontinued it and cut them loose, or we went and we dropped them off in the ER, but there was nobody around to take over for them, to take over for us, and we just let them go. And we're like, okay, well, somebody will eventually show up. If you would turn over your patient now as an EMT, and you would show up at the ER and start to give a report and say, okay, the patient's now yours, and you walk out the door and come to find out that was the unit secretary, or that was the x-ray tech, or that was the pharmacy technician, or maybe it was a nurse's assistant that you just handed off patient care to. A lot of what is in your scope of practice isn't in the scope of practice of any of those other healthcare providers. When you look at ancillary personnel, such as x-ray, physical therapy, laboratory, pharmacy, they don't do whole patient care. They don't care for the whole situation. They don't have the training to deal with the emergencies. So you need to turn your patients over to at least a licensed practical nurse, an LPN, or an RN, physician, a mid-level provider like a PA or a nurse practitioner, or an EMT or above, so a EMT or a paramedic. You need to make sure that you're transferring care to those people when you are providing care to a patient that has medical necessity. Occasionally we have the odd situation in which we're taking a patient from the hospital maybe back to a nursing home via ambulance, and even in those cases you should turn that patient over to the nurse that's on duty. Although the majority of the help you might get putting this patient back in bed is probably going to be aides, you should try to hand off the paperwork and give your brief report to the nurse that's in charge. Good Samaritan laws. So what is a Good Samaritan law? Good Samaritan laws have to do with granting immunity from liability if a person acts within good faith within their level of training. The very next statement here says this rarely applies to on-duty personnel, and that is very true because the rules of negligence apply once you're on duty. Good Samaritan law might cover you if you're on vacation out of state and you stop and you render aid and you hold C-spine or you do CPR, but in most cases, once you have stepped across that line from kind of standard first aid / CPR stuff and into emergency medical technician stuff, a lot of times you are no longer going to be covered by the Good Samaritan laws. This does not protect persons from gross negligence or violations of the law. If you willingly do something incorrectly, the Good Sam statutes are not going to cover you. You are hanging yourself out to dry. So think about it here. You arrive on the scene of a patient in cardiac arrest. Family says she has a DNR now, but don't know where it is. How do you handle this? If they cannot generate proof that this patient has this DNR order, you really are obliged to start providing care. If they come up with this order, you can get on the horn with medical control and discuss it and maybe terminate efforts. But if this case arises, I would say start treating your patient and immediately get on the phone with medical control and say, here's the situation, this is what we're being told, what do you want us to do? Because this is going to shift that decision to somebody of a higher medical authority. You are off duty and arrive on the scene of a vehicle crash. Police and EMS have not yet arrived. Are you legally obligated to stop and render aid? Again, that depends on your system. So that's really a protocol question, an operational guidelines question that would have to be asked. And in most cases, most of us would say, I'm going to stop and render basic aid until other EMS can arrive. That's an ethical decision. Legally, that depends on your system. So confidentiality. Okay, when we bring up confidentiality, most people have already heard of this ugly, scary monster called HIPAA, which stands for Health Insurance Portability and Accountability Act. It's HIPAA, not two P's, it's two A's. HIPAA, and we're going to talk about HIPAA in a second here, but HIPAA, confidentiality is much more than HIPAA. The information on the patient's condition, history, treatments, this is all confidential. It can be shared with other healthcare personnel as a part of the patient's continuing care. So when you go and drop this patient off at the hospital, the person that's taking over care, or the persons, maybe it's a doctor and a nurse, you are obliged to share that information with them to keep the patient's care going in the right direction. You cannot just walk around the hospital talking to every nurse on site and telling them, oh, here's what we picked this guy up, and here's what his problem is. That is a violation of confidentiality. They're not directly involved with this patient care. They do not need to know. Sometimes there are certain situations in which some information does get automatically relayed on. Most patients will sign saying it's okay to share my information with my insurance company. This is a lot where HIPAA comes in. And in those cases, we can share information to get payment. We can, in some cases, we also have to automatically turn over certain types of information. One last, I guess, couple of things here on confidentiality. If they subpoena the records, of course, then you are required. Subpoena is a lawful order from the court saying that you got to release this info. Sometimes when we're out discussing things, when we're talking, saying things that are potentially seen as false or injurious, this is slander. So when we're giving information verbally that's maybe harmful is considered slander. Once you write it down, it's considered libel. If you have a difficult time remembering the difference between libel and slander, remember libel and Bible are both written. So slander is spoken, so the S is spoken. And then the last thing on HIPAA, HIPAA has brought a lot of changes in record keeping. It really honestly applies to electronic storage and transmission of medical information. It is not everything there is with confidentiality. A large majority of it does pertain to HIPAA, but it really has to do with the way that electronically records are stored, accessed, and transmitted. So, medical identification devices, this is just a nice way that some patients can help us understand, hey, there's a medical problem I potentially have here. You can see this picture here. It says diabetic, type 1, insulin dependent, and hypertension. So it's just kind of giving you an idea of a direction to head with assessment and treatment of this patient. Often these are found in bracelets, necklaces, anklets. Sometimes they're in wallet cards, say in your wallet or purse. And I'm starting to see more and more people get tattoos that have medical alert information on them. I've seen some that almost look identical to, say, this medical alert bracelet you see here, tattooed just in that very image on their wrist or on their chest. So medical alert is really very helpful for us to help us start to determine what might be going on with this patient. Organ donors, persons with a completed legal document allowing the donation of organs and tissues in the event of death. They can be identified by their family members, donor cards, driver's licenses, And the receiving hospital or medical direction should be advised, depending on what your protocol is. Our biggest job in EMS when it comes to organ donation is just simply identifying potential donors. It really doesn't change the way we do anything in EMS as far as their organ donor status. We're still going to treat this patient the same way. It should not make you think, well, I normally wouldn't do CPR on this person, but I'm going to do CPR on this person. That way they can maybe save some of their organs and do a transplant. That is not physically possible right now. If the patient did not have reliable, continuous blood flow through their major organs, they are not suitable for transplantation. So hearts, lungs, livers, kidneys, those organs pancreas must have a constant, decent blood flow in order for them to even be suitable for transplantation. CPR does not make them suitable. There are still things that can be transplanted even if the patient has died, and they can be harvested for up to about 24 hours after the fact. And these can be things like heart valves, skin, eyes, blood vessels, bones, and some parts of the colon. These sorts of things can be removed and transplanted even without blood flow. So it doesn't make a big difference in what we do. Our biggest goal is just to say this is a potential organ donor and relay that information. Safe haven laws, this is all going to depend on really probably local systems, but under certain laws, a person can drop an infant or child at any police, fire, or EMS station, or deliver the infant or child to any available public safety personnel, basically saying I can no longer care for this child, take them. And basically what we're doing with this is we're just being a resource. I'm not saying we're going to be a babysitter. It's just saying, hey, we would much rather you drop this child off with us. We'll get in contact with the right personnel that will take it from there, as opposed to don't just go, drop your kids off out in the middle of the forest. Don't stick them in the car and drive it into the lake. It's really trying to just protect these children from being neglected or abused, giving parents or caretakers another option. Crime scenes. Crime scenes, of course, are things that we deal with actually on a fairly frequent basis in EMS. Location where a crime was committed or anywhere that evidence can be found. Once police have made the scene safe, then our priority is patient care. And in most cases, law enforcement wants us to care for that patient. They want us to do everything we can to make sure that that patient survives, because if that patient dies or becomes permanently unable to communicate, then they can't get information from probably one of the best witnesses that there is. So know what evidence is, take your steps to preserve that evidence. So when we're talking about what do we have for evidence, this is really anything that has any potential to have been involved with this incident, whether it's clothing, it's hairs, it's blood drops, fingerprints, belongings that have gotten moved. Those sorts of things are all potential evidence. So things to kind of keep in mind. Number one, avoid touching things that you don't need to be touching. So if you can avoid leaving fingerprints and footprints, great. Don't walk straight into the room. Try to walk around the edge of the room. If law enforcement's around, ask them where they want you to go. But avoid walking straight in the room. You may cover the footprints that were already there. Hopefully you have your gloves on already so you don't have to worry about fingerprints, but you can smudge fingerprints. So try to you're probably not going to leave many of your own, but if there are things that have been touched by a perpetrator, try to not touch them. There are lots of microscopic evidence. Dirt, carpet fiber, trace blood, so on and so forth, hairs I mentioned. You may want to ask the law enforcement, hey, when we're done with this sheet this patient's laying on, do you want us to save this for you? Conditions of the scene and the patient themselves, you need to note. You need to keep as many mental notes as possible and eventually get those written into a formal document so it can back up whatever you saw, back up your memory. Most of us probably can't remember what we had for lunch last Friday, so to be asked to have to describe a crime scene would be very difficult as well. So remember what you touch. Tell the police what you've touched or moved. If you don't have to move it, don't. If you need it moved or you need a piece of information, say you need law enforcement to get into that patient's purse and get out any ID that might be in there, you discuss that with law enforcement and they will help you accommodate that. They want to assist you in doing what you're doing, but they also now have a very big job themselves to do. And this might not even be something you would think about on a regular basis. Maybe the patient was crossing a street, got hit by a car, and you packaged up your patient, and now you want to pick up that patient's purse to take along with her. However, wherever that purse fell or wherever it was thrown to might be a specific indicator of speed and so on and so forth. So just stop and think. Minimize your impact on the scene. Avoid using anything in there in the locale. So if you have to go to the bathroom, hold it. Don't go and use the patient's toilet because you can. There may be evidence in the toilet. You may disturb something. If there are gunshot wounds, stab holes, nooses, whatever, avoid destroying that actual evidence. If you have a patient with a noose around their neck, they've hung themselves, don't cut the knot. Cut somewhere along the running part of the neck loop. Don't cut directly through the holes because there may be specific microscopic evidence associated with that hole. Cut around it. So don't use the patient's phone. Don't go rummaging through things. So work with the police. They're going to help you. You help them. And then, of course, document. Some mandatory reporting guidelines. When do we kind of skip over the confidentiality things? It's not really skipping over confidentiality. It's just certain things that were required by law to report. We're not giving lots of details, but we're getting other authorities involved. In both Iowa and Nebraska, child and dependent adult. I don't prefer the term elderly. Dependent adult works better because that includes people who maybe don't have the faculties, the mental capacity to care for themselves. So those are mandatory reporting. You must file a report within 24 hours. You must make a verbal report, 48 hours a written report to the appropriate authorities. In any suspected abuse or neglect case. You don't have to prove it. That's the job of the investigator. You just have to suspect it, and if you suspect it, you report it. Anytime that there is an act of violence, law enforcement should be contacted. Sexual assaults, stabs, gunshots, abuse, or not abuse, we'll say assaults, animal attacks. Law enforcement is probably going to be involved as well as animal control. Patients under the influence sometimes also have to be reported. Sometimes we have people who will skip calling 911 because they don't want law enforcement to know. And if you call 911, you might get a police car, a fire truck, and an ambulance to show up. And if you don't want the cops involved, maybe you just directly go to the ER via private car. Well, guess what? Cops are still getting called, but it's easier for them to cover their tracks if they're, let's say, gang violence. if the police don't actually come to the scene. So in review, obviously, numerous concepts here to discuss. If you haven't read the text, please go back and read the text by now. Remember to concentrate things on kind of morals, your consent issues, refusals, negligence, and abandonment, as well as crime scenes, patient confidentiality, some questions to consider. Critical thinking. You respond to a motor vehicle crash and find a seriously injured patient. He has no pulse and you're about to begin CPR when someone says, "Don't do that. He's got cancer and a DNR." No one has the DNR at the scene. Do you start and transport the patient? Again, you're probably going to have to start, but you can always contact medical control and see if they need you to continue.